So welcome so much. I'm so grateful to you and so grateful that you're here joining today for our discussion really about a thyroid crisis or thyroid emergencies killer in the critical care unit. And I think it's always important to just remind ourselves when we talk about thyroid function and other types of function, just to remind ourselves always that even though what we learned in nursing school is the pituitary is in charge, it isn't really the pituitary that's in charge, it's the hypothalamus. The hypothalamus responds to presence or absence of hormones and presence or absence of osmolarity, and it communicates to the pituitary gland. So even though we talk about the pituitary as being the master gland, pituitary is under organ control, and that would be the hypothalamus. Hypothalamus actually controls the pituitary. And the pituitary either stimulates or inhibits a number of other hormonal organs. We know that it contributes to the kidney, contributes to the pancreas, the adrenal glands, the thyroid glands, and also the reserve pathway, the vascular reserve pathway, the hypothalamic originated vasopressin. And vasopressin, of course, is stored in the pituitary gland, but it's actually made at the hypothalamus. Now, nobody really cares that much if we understand all of this. What we actually care about is appreciating the relationship of hypothalamus to pituitary and pituitary to target endocrine gland. So our purpose today, there are many things to talk about every day, all the time. I'm just going to turn a little so that light's not shining behind my head. Every day, every time. What we're going to talk about today really is hypothalamus regulation, the pituitary regulation of the thyroid hormone. So the hypothalamus releases thyrotropin, releasing hormone. I love that word, releases. And it communicates to the pituitary, and the pituitary either stimulates through the thyroid stimulating hormone, or it inhibits the thyroid stimulating hormone. And that acts at the thyroid gland. The thyroid gland then releases hormone, and that hormone is active at the target tissues. So really, really important, because above everything else, my friends, of course, I'm concerned about your metabolic qualities, but the thyroid hormone, most important, is to remember that the thyroid hormone helps our patients retain their responsiveness to catecholamines, aka neurotransmitters, aka norepinephrine and epinephrine. So really, really important when we're seeing a response that we actually would consider is an epinephrine or norepinephrine response, hypertension, tachycardia, always think about the thyroid hormone. When we see hypotension and bradycardia, always think about the thyroid hormone. Now, that's really simple. That's really straightforward. Without thyroid hormone, you cannot respond to circulating catecholamines. Without thyroid hormone, you cannot normally metabolize glucose. So in order to survive critical illness, I must be able to respond to catecholamines, and I must be able to metabolize glucose, two really important things that are significantly and profoundly altered when we have thyroid disease. Always important to remember about that thyroid gland. It's a beautiful gland. It's the largest endocrine gland, 20 grams in an adult, 2 lobes, and they lie on either side of the larynx. So one of the things we worry about a lot is when unsophisticated persons do a crike. We're always worried about nicking the thyroid gland or causing some other trouble. And of course, really important that we're only going to go directly into the trachea. So a lot of times our concern with intentional wellness, but not well trained about doing cricothyroidectomies is really, really important. Cricothyrotomy is what I mean. And we're just using a needle to go into the trachea. We have to really be concerned about that relationship to the endocrine gland. Okay, so want to make sure we appreciate, because this is not meant to be the end all and be all and make you be able to diagnose all tests of the thyroid gland. I just want you to see I'm using 2 colors of arrows, a full arrow and a dotted arrow. The hypothalamus, when it recognizes that you're having a hypotensive response, a bradycardic response, the hypothalamus will release thyrotropin releasing hormone that will stimulate the anterior pituitary, which will release thyroid stimulating hormone. The thyroid stimulating hormone will then target the end gland, the thyroid gland, and the thyroid gland will release the two major thyroid hormones. There's a lot of thyroid hormones, T4 and T3. And those hormones will travel to the target cells. And at that point, when the target cells have the answer to their request, meaning I got more glucose, I'm responding to circulating catecholamines, there will be a backward or a negative feedback loop. That dotted line goes back to the anterior pituitary saying, stop stimulating the thyroid gland. And in that negative feedback loop, back to the hypothalamus, stop stimulating the pituitary. So my target cells are actually in charge. They're who are asking for thyroid hormone, and they're who say, we've had enough thyroid hormone. But by the way, my friends, this is a really, really, really delicate balance, a really delicate balance. And it is all based on cellular communication with hormones. Okay, so the two primary hormones that we talk about, lots of information here because I'm in love with the thyroid gland. I love to talk about it. But our two hormones that we are most concerned about is the most active hormone, T3, and the precursor to T3, which is T4. Now, typically when we are evaluating patients, we will look at T4 and or free T3. Okay. Free means I have a bond or a binding site on that hormone that can attach to the cell. So T3, because of its free bind, actually is the most metabolically active form of thyroid hormone. But in general, we don't even look at that when we're doing a casual thyroid evaluation. By the way, I would never encourage that. But a lot of times we're doing a casual thyroid evaluation, we look at T4 and we look at thyroid stimulating hormone. If your T4 is down, your stimulating hormone should be up because you need more thyroid hormone. So if T4 is down, thyroid stimulating hormone should be up. If T4 is up, thyroid stimulating hormone should be down. Pretty straightforward, relatively simple. Not everything you need to know to be an endocrinologist or a thyroidologist, just basically in the ICU, when we look at a basic evaluation of thyroid gland, we look at T4 and we look at TSH. If your TSH is up and your T4 is up, you're having a reason for that. If your TSH is down and your T4 is down, that's a major failure. So really have to actually evaluate this appropriately and try to extend that to our understanding. I'm going to move through here and just say, just want to remind you, T3 is metabolically active, okay? Metabolically active. RT3, so a lot of times you'll see RT3, that's not free T3, that's not FT3. RT3 is inactive hormone. Again, for us in the ICU, typically all we're doing is looking at TSH and T4. But if you really want to get a good overview, it should be TSH, T4, and T3. T3 has that open bond which allows it to attach to the cell. That's what makes it metabolically active. Now, on your thyroid hormone, you have four binding sites that bind to iodine. Okay, now that's really important because in one of the drugs that we give patients, amiodarone, it is actually an iodine-based agent. So because as we break down the active component of amiodarone, we free up iodine, iodine bonds to the T3, converts it to reverse T3 or T4, inactive, meaning that long-term amiodarone users will frequently have severe and profound hypothyroidism. So they come in through EMS, they get admitted to your MICU or your CVICU, or they had a motor vehicle collision, they get admitted to your trauma surgical unit. And despite the fact that they have profound metabolic acidosis, they're bradycardic and hypotensive. The first thing you should be thinking is thyroid hormone, especially if the patient is an amiodarone user. So we need a thyroid profile to evaluate those patients. Okay, so most importantly, when we're thinking about the thyroid hormone, T3 is the primarily metabolically active form. T4 is the reserve for T3. When that goes up, that increases your metabolism, and it's stimulated to be released whenever metabolism goes down. You always stimulate to release that hormone when metabolism goes down. But it also, thyroid hormone is very connected to the other hormone known as calcitonin. Calcitonin actually promotes the reduction in your circulating blood calcium. So when you have hypothyroidism, you'll have a low calcitonin level. You're going to leach calcium out of the bones, and your blood calcium levels are going to go up. So when we're looking at these individuals, these are going to be important topics for us. But in critical care, our most important hormone is going to be T3 and T4. That's what we're really going to look at. So I want to start first with the first kind of thyroid dysfunction that we see. And it is not really a thyroid dysfunction. It's called euthyroid 6 syndrome. It's a non-thyroidal illness. It means you don't have a problem with your pituitary. You don't have a problem with your thyroid gland. What actually happens is a conversion of free T4 or free T3 to reverse T3, which is metabolically inactive. And that typically occurs in relationship to medications. Glucocorticoids, iodine-based medication like amiodarone. It can occur in patients who have type 1 diabetes. It can also occur in patients who are malnourished. This is not a thyroid disease, my friends, not a thyroid disease. And you can actually cause the patient to be hypothyroid if you give thyroid supplementation, euthyroid 6 syndrome. So in euthyroid 6 syndrome, what we typically see is we're at that bedside. We have a patient. Oh my God, I can't believe I'm even saying this, but we have a patient who is hypotensive and relatively bradycardic, and we're titrating up and up and up on our neurotransmitters. We're going to step back from that bedside and say, is it possible that this patient has euthyroid 6 syndrome? Now, euthyroid 6 syndrome will not be evaluated by TSH and T4. TSH will be up, T4 will be responsive. What's really important in euthyroid 6 syndrome is the level of reverse T3, which is metabolically inactive. So I would tell you that whenever you have patients where you are really concerned about the failure of responsiveness to epinephrine, norepinephrine, you should always question, is it possible that A, they're hypothyroid, or B, that they have euthyroid 6 syndrome, ESS, which is caused by inactivation of the appropriate thyroid hormone. It's not a pituitary failure. It's not a thyroid failure. It's a failure of the hormone to be free to bind at the cellular level because that hormone has been iodinized. Okay. Really important. And actually, it occurs quite a bit in our critical patients. T3, T4, not helpful. Okay. TSH will stay low to normal. T3 may drop first, T4 may decrease, but the way you really evaluate this is free T3, reverse T3. Now, in our purpose to go beyond euthyroid 6 syndrome, which I think actually occurs a lot at your bedside, and everybody here who works with lifelink patients, you will remember that you are always doing thyroid supplementation in those patients because that makes them more responsive to circulating catecholamines, helps you to maintain their blood flow and their blood pressure more effectively. Just think about how we do it for all of our lifelink patients. we should be considering it in all our critically ill patients. But I now want to talk about the two wide differences in critical care, critical illness, killer critical illness that occurs with thyroid dysfunction. That would be hypothyroidism and the severest of hypothyroid disease, myxedema, coma. That's this patient here with the really almost closed eyes. And then hyperthyroidism and the exacerbation of hyperthyroidism, which will be a thyroid storm. Thyroid storm has a lot of different types, one of them, most important one being Graves' disease, and that's being represented here by an individual who has thyroid eye disease, and that's the bulging eyes. They can't close their lids over their eyes. They can never close their eyelids over their eyes. They have severe and profound exophthalmos. Now, for us, I want us to remember when we're talking about hypothyroidism in critical care, right? My patients might be intubated. I'm not really looking at whether they're forgetful or whether they have mental slowing. I may not be truly able to evaluate whether or not they have paresthesia or carpal tunnel syndrome, or whether they can hear or not. If I actually evaluate their tendons, I might see that they have a hyperacute response, but they don't relax. Okay. I'm not going to really do any of those. I'm going to remind myself of this: bradycardia, hypotension, decreased cardiac output, despite volume, despite inotrope, despite vasopressor. If I look at them on EKG, they oftentimes will have a lot of effusion around the heart on echocardiogram, pericardial effusion, and because of the effusion around the heart is farther away from the chest wall, so the voltage on the EKG looks poor. Oftentimes, these patients will have very significant bilateral dependent edema. Guess what that looks like? It looks like heart failure, and it absolutely does look like heart failure. The only way I can really differentiate is that I've done a thyroid profile. So that's what I'm saying to you. You have to be great detectives, because it's very easy to say this patient's got heart failure, but his heart failure is actually enabled by his hypothyroidism. And so we have to think about supplementation of thyroid hormone to actually restore normal cardiac function. Now, we see a lot of other things that patients have when they're hypothyroid, but most of them we're not worried about in the ICU, right? You may see that the patient has reduced sodium in the blood, but that's going to look like heart failure, or it's going to look like renal failure. Again, you're saying this patient should be responding to vasopressor, they should be responding to inotrope, and they're not. So now I'm going to do a thyroid profile. Okay, everything else, these are all really important. They're not necessarily important to us in critical care. They are all part of hypothyroid symptomatology. They're all concerning to us in symptomatology. Now, if this is an ongoing hypothyroidism, oftentimes what we'll see when we look at the face is that alteration in their facial features. They're very coarse, they're puffy. They may actually look like they're mildly jaundiced, although usually it's a little bit more orange. But the other thing is they can't manifest a temperature. Lots of times their temperatures are 35 or 36, and they have severe, profound hypothermia, which is really significant. And because they are hypometabolic, their cholesterol and triglycerides are up because they're not using them metabolically. Oftentimes the family will say, well, over the last 3 months, they've gained 50 pounds. That's a great clue. It's not really the thing we think about in critical illness, okay? If we are first evaluating these patients, we see that they have an altered mental status. They're not very oriented. They're very exhausted. They have psychotic delusions. They're very confused. They could be hypothyroid. They could have a stroke. This could be medication effect or sepsis or CO2 narcosis. But if I don't draw a thyroid profile, I won't know. Myxedema coma is the exacerbation, the acute exacerbation of profound hypothyroidism. Bradycardia, cold, hypotensive, pleural effusion, looks like they've had a stroke. And here is this patient, how she looked 2 months ago and how she looks today. This is myxedema coma. Now, she's not comatose. She's had some treatment, but this is the facies of somebody with severe and profound hypothyroidism. So again, when we're talking about patients who have exacerbation of hypothyroidism, which can occur under your care because you don't have the patient's thyroid history, or because the patient did not know they were hypothyroid, and now they have acute, profound, severe metabolic stressors, critical illness, and they are hypothermic, okay? They are hypotensive, they are bradycardic, they are hypoventilating, they have a depressed mental status, they're asleep and you can't wake them up. Mama won't wake up. This is really significant. And this is really the list that should engage you to actually say, is it possible that this is an exacerbation of hypothyroidism? Maybe we don't know that from your previous medical history. Maybe it's never been diagnosed, but your critical illness, your infection, your injury, your myocardial infarction, your stroke has exacerbated the need for thyroid hormone, and now the patient is in myxedema coma. Almost always, we start with the precipitating illness or event. You can see everything listed here. It's like everything that happens to patients, okay? And then we say we're diagnosing this by the big trio: hypotension, bradycardia, hypothermia. The big trio: hypotension, bradycardia, hypothermia. And you can't resuscitate them. You can't warm them up. You've got warm blankets on them. You've got warming blankets on them. You might have even put an Arctic sun on them. Oh my God, hopefully not, because that's going to be a problem, because they can't match that metabolic demand getting warmer. You've got to treat them with thyroid hormone before you ever try to warm them up. So this is a major problem for us, because a lot of times we're reacting to the symptom, but we're not really looking at the disease or the deficit. So here's an EKG from one of my patients who came through the ECC in myxedema coma, and you can see that her QRS is very, very, very tiny. You can see also that she has a prolonged PR interval, and she also, although it's very hard to see because you can't really see the T wave, this really allows the EKG, but you could actually see that right here, looking at the QRS, she has a prolonged QT syndrome, which is the hallmark sign: prolonged PT, decreased voltage, prolonged QT, prolonged QTC. So if you have a doubt, you have a patient who comes in who is hypothermic, hypotensive, and bradycardia, by the way, you need to treat that patient with thyroid hormone. When in doubt, and if it's life-threatening in front of your face, you're going to give them some IV levothyroxine. Usually you would not give more than 0.25 or 0.50. You might give 1.0, but if they have a cardiac deficit, it may overwhelm their cardiac function. So when in doubt, you're going to treat with a really low dose of levothyroxine. You might even give 0.125. Always good to give on the lower side to see, does that improve the patient's ability to raise their temperature? Does it improve their heart rate and their blood pressure? Then you have your answer, okay? Now, again, remember, we'd love to test you, but sometimes things are happening and they're happening really fast. So the most common will be TSH and T4, and then we'd like to add T3 or free T3. And if we're looking for euthyroid syndrome, we're going to do reverse T3, which is the metabolically active form of thyroid hormone, which means that I'm acting like I'm hypothyroid at the target level, but my pituitary and my pituitary and thyroid gland are relatively normal. Okay. So we're going to look at you, we're going to evaluate you for all sorts of things. Like, we want to see if you're septic, so we might do a blood culture, we'll do a urine culture, we'll look at white count, but all those things are going to tell me about causative agents. They don't actually tell me about hypothyroidism. Hypothyroidism is an index of suspicion generated by you, the bedside nurse, and confirmation with appropriate laboratory testing. Okay. Now, here's the thing. With these patients, they are poikilothermic. That means they're like a lizard. They'll get cold in a cold room, warm in a warm room. The problem is that if you warm them up, what's going to happen is that's going to increase their metabolic demand. So really, really important to remember that you don't want to warm them up aggressively, right? If you warm them up aggressively, they will vasodilate. They will have profound vascular collapse. They almost always will have a cardiac arrest. They cannot maintain their metabolism. So that's going to be profoundly important for us to remember. No aggressive rewarming, only passive. That's why I said you come into the ECC, you're really cold, you're bradycardic, you're hypotensive. Before I put an Arctic sun or even a blanketrol on you, I need to actually ask the question, is this hypothyroidism? Because I cannot aggressively rewarm you. I can only do that with warm blankets, no electrical blanket activity. Now, they have a very profound, significant loss of diaphragmatic regulation. The thyroid hormone is essential for diaphragmatic function, so they frequently will need to be intubated. And the reverse is also true, my friends, is that if I have hypothyroidism, I am never going to be able to wean off a ventilator. So I would always tell you, by your third attempt of extubation for a patient who has failure, I would always consider measuring the thyroid hormone to actually see, is this why I can't wean you off the ventilator? You have a diaphragmatic failure related to that. If the patient now drops their pressure anymore, my friends, they're probably not going to survive. This is always prodromal and ominous. So if you have a rapid drop in blood pressure, you typically have a secondary event, like you might be hemorrhaging, you may have had an MI. So we're going to look at secondary events. You're going to get an EKG from me. I'm going to look at your hemoglobin hematocrit, because I want to be sure that I have not got a secondary problem. But you will drop your blood pressure if I rewarm you, and you will not be able to bring that back up. So again, be very careful about rewarming these patients. Now, the first thing we're going to do with these individuals is that typically they have coexisting primary or secondary adrenal insufficiency. So they're going to get some hydrocortisone, and you can stop once you get their cortisone level to normal. But now I want you to remember, these are micrograms, okay? So we're going to use, if we're going to give you thyroid hormone therapy, if you're an older person, if you're a small person, if you have cardiac disease, you're going to get 0.05 or 0.0125 every day. I'm going to give you a very, very, very low dose. Then after I see that you respond to the thyroid hormone, I'm going to increase. And I can go up to about 500 micrograms IV of levothyroxine per day. Okay, then I'm going to try to convert you to oral therapy so that you can go home. So what I want you to remember is you're always going to consider hypothyroidism in a person who presents with that constellation of symptoms, right? Hypothyroid, hypothermic, bradycardic. If you don't have an explanation, if the patient's not responding, think about doing a thyroid profile, and when in doubt, treat, and always treat with low level, 0.05 or 0.0125, very low level, because you don't want to endanger the cardiac structures or cause other types of issues. Okay, so what's going to happen as I treat you? Your cardiac output is going to start to come up. You're going to actually start to improve over the next couple of days. As I give you levothyroxine, the first thing I'm going to see is you're going to increase your heart rate, and you're going to increase your blood pressure, and you're going to increase your cardiac output. Over the next 24 hours, your TSH, which in this case will be very high, your T4 and T3 are very low, TSH is very high. As I give you thyroid hormone, your TSH will start to come down, and your T3 levels will start to come up. That's typically around day 3 or day 4. And you now can recover your ventilatory response to carbon dioxide or lack of oxygen. That'll happen at around 7 days. I want to remind you again, if you are having trouble withdrawing your patients from the ventilator, after third time, I would always suggest that you take a look at thyroid hormones, which are absolutely necessary for diaphragmatic function. So as soon as possible, you're going to change those patients over to oral therapy. You're going to increase whatever you gave them by IV. You're going to increase that by almost half to an oral dose, because you're going to lose a lot of integrity of the oral dose in the gut wall. So that's going to be really important. Okay, so this is one patient, 60-year-old man, presents with fatigue and alopecia, severe hair loss, and his TSH was greater than 75. So TSH should never be this high. TSH is up. His free T4 was 0.2, which is extraordinarily low. So he has actually primary hypothyroidism. Same patient, look at him here, lost all his hair. Look at him here. This is after treatment with Synthroid. So you can see really has a lot of recovery. Now I'm going to switch over to the other killer, which is hyperthyroidism. And we don't actually see patients usually with this severe thyroid eye disease. unless they've just not been treated and they come into the hospital with this. We don't see them in the ICU with exacerbation to thyroid eye disease like this. Exophthalmos is typically a more chronic condition. You see it after some period of time. But just remember that hyperthyroidism means that you have excessive release of the thyroid hormone, T3 and T4, which means you are profoundly hypermetabolic. You can't gain a pound. You poop all day. Your heart rate is up. Your blood pressure is up. Your cholesterol and triglycerides are down, 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 down. You are in thyroid crisis, thyroid toxicosis. So symptomatology, again, some of these symptoms won't be things that we evaluate because we're in the ICU, right? They can be very anxious. They have a lot of weight loss. They want to eat all the time. They cannot tolerate heat, and their temperature is really high because they're always hypermetabolic. They're always producing heat. Their temperatures are frequently 39, 39.5, 40. You can't treat it, okay? They have very significant cardiac stimulation, and it actually, one of the most common causes of atrial fibrillation is hyperthyroidism. So that's always something we're going to think about. Now, remember, I said they're going to poop all day. They can't concentrate. They're just really so agitated and anxious. They appear sometimes like they're on methamphetamines, but they're really just hyperthyroid. They can't sleep. They're irritable. They may not be menstruating, even though they're in the menstrual age. And they may have some infiltration of fluid and edema. That's really called myxedema. And that can cause that exophthalmos. Some patients have goiters, some patients don't. So we're not always looking for an enlarged thyroid gland to tell us whether or not they're hyperthyroidism. What we're going to do in the critical care is we're going to see this patient has reflective tachycardia that I really am having some trouble getting under control. 15% of them have new onset atrial fib with rapid ventricular response, and they have a high cardiac output. Now, sometimes we're like, oh, we're so happy, except this patient is metabolizing themselves to death. They're sweating, they're tremoring, they cannot gain weight, they're consuming all their glucose, they're almost always hypoglycemic, and they're consuming their cholesterol and triglycerides. So cholesterol and triglycerides are low. Okay, now that's because they have this really high metabolic rate, a very high metabolic rate. Typically, they have a very significant vasodilation, and when we do a calculation of systemic vascular resistance, they have a low SVR. So that looks extraordinarily like shock, like septic shock. This is not septic shock, and it's not going to respond like septic shock response, which is to volume and vasopressors after antibiotics. These patients are not going to respond because they have hyperthyroid disease. So hyperthyroid treatment, so this patient is hyperthyroid. She doesn't have full exophthalmos. What you're seeing here is this patient has bilateral goiter, and you can see her neck. Now, goiters sometimes produce thyroid hormone. Sometimes they don't produce thyroid hormone. They're not definitive in terms of diagnosis. But by the way, your precepting student, your APP, your resident, your fellow, your attending, your endocrinologist, your nephrologist, the next person, mom, dad, everybody should not be palpating that goiter. Every time you palpate the goiter, you hyperstimulate it. So only one person should be checking for that goiter, and that should be the most experienced person. Even though you're going to want to touch it, you're going to want to feel it. Remember, you're overstimulating it and encouraging the release of thyroid hormone. The number one thing we're going to do for somebody who's got hyperthyroid or hyperthyroid crisis is beta block. Beta block actually blocks the uptake of the active thyroid hormone at the cellular level. So that is the first thing we're going to do. That's going to help us control that heart rate. It's going to help us narrow the pulse pressure, which is really wide because we have dilated vessels. It's going to decrease palpitations, decrease anxiety, decrease sweating. And the most common beta block therapy that we use, at least early, will be propranolol because it's shorter acting. Long term, we're going to put patients probably on metoprolol. It's a longer acting beta blocker, and it's going to give us a lot more bang for the buck. The second thing we're going to do, so the first thing we're going to do is we're going to block the hormone from uptake at the cellular level with beta block. That's going to be the first thing. The second thing that we're going to do is we're going to give the patient some form of iodine. That form of iodine is going to iodinize the T3, converting it back to T4 so that it is less metabolically active. And then we're also going to inhibit the thyroid gland. So we're giving these hormones, we're blocking the conversion by basically by blocking the release of iodine from the functional thyroid hormone, and we're going to block the thyroid gland. So now we're just going to talk about a patient that came through the ED. She did not come to the ICU. She actually had quite a few problems. 29 years old, been to her doctor saying, my heart beats so fast, I feel so bad, can't gain any weight. Probably didn't mind that so much, but she's like, still my heart beats so fast, can never sleep. And her physician just did a basic thyroid panel, and she had a very significant elevation in T4 and T3, and her TSH was down. Now, the TSH being down is normal. You shouldn't be stimulating the thyroid gland when your T4 and T3 are up. So T4, T3 up, TSH down. She's diagnosed with hyperthyroidism due to Graves' disease, and lots of discussion about treatment. Can we irradiate it? Should we take it out? Or do you want to be treated with iodine? She basically with a thionamide, which is an iodine agent. But she didn't follow up. She didn't come back to the hospital. She started on the drug. She lost her job. She lost her insurance. She couldn't afford her medication anymore. So, of course, she comes back severe. Take a look at that. 50-pound weight loss now. She already was underweight. She normally had been around 130 pounds. The first time she was seen, she was 99. She comes back, she's barely 50 pounds. So she looks like severely anorectic, has terrible tremors, palpitations, diarrhea, has proximal muscle weakness. She has no muscle left. And she actually looks like somebody who's anorectic. That was the first assumption, was that she had acute anorexia or bulimia, but that was not the issue. The issue was that she had profound thyroid shock. When they did her labs, her TSH was undetectable. Normally, you just have a low TSH. She had no TSH at all, and that's because her free T4 and her free T3 were 15, 20, 30 times normal. She had such high circulating thyroid hormones. That, of course, leads to thyroid storm. Now, we don't really know what the clinical features of this are. We just know that when you have hyperthyroidism and then you have a secondary event, you now have a profuse, profound, life-threatening decompensation of your metabolism. Now, we rarely see thyroid storm anymore because we have so much better access to primary care. But when if we see these patients, you really have big four: profound, uncontrollable hyperthermia. And by the way, if you do not want to give these patients salicylates, because that makes their thyroid hormone more metabolically active. So you have to use something like Aleve or Advil. You can't give salicylate. You don't want to give them acetaminophen. So you don't want to give them aspirin. They can have Tylenol, but they cannot have aspirin because that causes conversion of their thyroid hormone into an active form. Okay, so they have profound hyperthermia. We're going to try to cool them. We're going to actively cool them. We're going to use Arctic Sun. We're going to use everything we got. We could put in a cool cath. We're going to give them Tylenol. We're going to give them Aleve. We're going to try to get their temperature down. We're going to put ice on them. Whatever it is you can do, get their temperature down. They'll probably present with a temperature of around 40 or 41. So again, if you're seeing those patients who are hyperthermic and you can't get them under control, always think about thyroid hormone. Typically, if they are awake and alert, they will be they'll be awake and alert, but they're not oriented, right? They're delirious, they're having psychotic hallucinations, they're going to be very combative, they're profoundly agitated. They often look like they're withdrawing from medications. So it looks like they're withdrawing from substance or alcohol or methamphetamine. They're so agitated. So again, just put on your thinking cap that this may actually be thyroid disease. Now, at Grady Hospital, we do still see some thyroid storm because we have lots of patients who are lost to follow-up, who aren't well diagnosed or well managed in the beginning. So we do often see those patients, not often, but I'd say about once every 6 weeks, we'll see patients in thyroid storm. In general, you don't see that much anymore. And they have a lot of cardiac deficits. They're very tachycardic. When we look at them, they have a profound diastolic dysfunction, failure to relax, which then leads to systolic dysfunction. And typically they'll have abnormal rhythm. Again, the most common being atrial fibrillation. So the most important defining features, high fever, usually over 40, and a significant profound abnormality in their mental status. Really, really important. Again, we're going to look at that tachycardia. They may be hypertensive, but high fever, mental status, tachycardia, hypertension. They may be vomiting, they may have diarrhea, they may have jaundice, but we may or may not know that. But tachycardia and hypertension are really easy for us to evaluate, and temperature is really easy for us to evaluate. Again, there's always a precipitating factor. One of the most common ones is they stopped taking their thyroid medication because they couldn't afford it. That's really important. That anti-thyroid medication, so the iodine, the PTU, or the other iodine potentiators, if they are not taking their medication, then they will go into that thyroid storm. So really, really important to look at that. And you can see from this list, they come in, we think they've had a CVA, we think they have heart failure, they've had an MI, they have a PE. We have to think about all these things that might be precipitating their thyroid crisis. And now the diagnosis has gotten very muddy. So these are not patients that are treated and treated in the ED because of their significant presentation. So again, we think about that differential diagnosis. Are you on methamphetamines or cocaine? Do you have NMS, neuroleptic malignant syndrome, meningitis, intracranial hemorrhage, malignant hyperthermia, or, by the way, oh my God, something I never had to actually even put on a slide before in the United States that I now have had to put on my slide, which is falciparum cerebral malaria. We now have, I think the CDC said we have a documented 25 cases of falciparum cerebral malaria. That's different than standard malaria. This is malarial infestation in the cerebral vessels and into the gray matter of the cerebral tissue. And it's horrendous. People are my experience with it was really in, I saw it in the malaria unit in Tanzania, Africa, at the Aga Khan University Hospital, where I was teaching a critical care course. They had 5 patients when I was there who had full-blown falciparum cerebral malaria, and they have very little treatment. So those patients basically are just having end-of-life care. So it is something to just be thinking about. I don't think we have to worry about it right now. It's not pandemic. It's not endemic. But it is here now because of the change in climate and the kinds of malarial insect carrying malaria propagation because of the change of our climate. Basically, we now live in a jungle. It's so hot, so humid, and it really is a really good situation for the growth of the larvae of these mosquitoes. Okay. So here's the problem. You come to us, you've got thyroid storm, and you have thyroid storm that's exacerbated when you're in our ICU. Mortality is pretty high. It's typically around 30%. So very first thing is you're going to obtain thyroid tests. You're going to load patients with iodine. You can do it orally or you can do it rectally. We don't really have it any other way. So for us in the ICU, it will typically be rectal administration. We can use Tapazole, PTU, Tapazole, and other iodine derivatives that we can use for our patient, okay? And then after we get them under control with their critical illness, we're going to think about what we need to do to help that patient over time. And remember, what we're going to consider over time is that they're going to be on iodine agents for the rest of their life, okay? They may also have irradiation if they have a goiter. We may have to remove the thyroid gland, making them hypothyroid, and then trying to always, for the rest of their life, give them the right amount of thyroid hormone. Okay, so very important for nurses, cooling blankets and aggressive. You must avoid aspirin. Must avoid aspirin, actually salicylates, right? You can use acetaminophen, which is Tylenol. You can use Advil or Aleve, but you must avoid aspirin. And you're going to give a lot of fluids and a fair amount of glucose and thiamine support, similar to what you might do in somebody who is withdrawing from alcohol because of this metabolic demand. And remember that they frequently present in congestive heart failure. So typically for these patients, we're going to use diuretic therapy. We may actually combine some digoxin, which works quite well in patients who are in thyroid storm. And then remember that we're going to actually block conversion of T4 to T3. So lots of different agents that we can use. We can use SKI or Lugol, which are iodine-containing solutions. We also are going to use glucocorticoids, which can help us a lot. That blocks conversion of T4 to T3. You should always keep that in mind when you're putting patients on steroids, because you may have some functional hypothyroidism that actually expounds itself when you got them on glucocorticoid therapy. It really works quite well in the autoimmune process, Graves' disease, which stimulates the thyroid gland. That can work quite well too, okay? Beta block, beta block, beta block, beta block. And they're going to need higher dosing. So remember, typically we're going to start with propranolol, then we can move on to other agents that have a little bit longer half-life, or if our patient is refractory. And then you got to figure out what was the precipitating event, right? Because something caused the thyroid gland to go into storm, something that was causing an alteration in metabolism. So that could be DKA, that could be HHS, that could be sepsis. We've got to look for the precipitating event. Okay. Now you're going to look for that source. So if the patient has an infection, now they have thyroid storm, they've got thyroid storm, plus they still have an infection and they're still septic. If it's DKA, they can have thyroid storm, but they are still in DKA. So they still need that treatment as well. So we want to remind ourselves that both of these exacerbations occur sometimes under our care because the precipitating event has stimulated the thyroid gland, and now we see the deficit or we see the excess of that thyroid gland. For hyperthyroidism, just want to remind ourselves as patients go forward that they now can have very significant heart failure or heart disease. So we're going to be very careful with these patients, going to be really aware that they have to come in for cardiac follow-up, and they have to do it pretty frequently. So after we get their thyroid gland under control, we're going to refer them to the cardiac clinic where they're going to be seen quite frequently. It's important to remember that you actually have to do some thyroid testing. You can't just make an assumption. You don't want to overdiagnose. If it's life-threatening, treat it like it's thyroid disease, but at the same time, always look at the thyroid hormones. And I want to remind you that there are over 20 thyroid antibodies. In women in particular, the answer may not be in TSH and T4. It may be in the antibodies. So if you suspect, you yourself, about you, your family member, your patient, suspect that there's a thyroid dysfunction, you don't just have your PCP run a TSH and a T4, although that's a great first step. If you really suspect that there's thyroid dysfunction, you need an endocrinologist. The endocrinologist will run a much bigger profile with a much bigger platform to be able to make a better diagnosis, since thyroid disease can be very insidious. Thyroid disease can be insidious until you are in an overactive response state, such as sepsis or trauma, surgery, where a lot is asked of the thyroid gland, and all of a sudden we discover that we're hypothyroid, or all of a sudden we discover we're in thyroid storm. So these are really, really, really important criteria when we're thinking about those two ends, thyroid storm, myxedema, coma. Always consider your ABCs and always remind yourself that I will never aggressively rewarm, but I will always aggressively cool my patients. And whenever you have any upper airway disorder in any conjunction like this, you should always consider thyroid disease. So again, the one I think we see the most is thyroid storm, life-threatening exacerbation of hyperthyroidism. It's the overactivity with sustained release and synthesis of thyroid hormones. And remember, fever, tachycardia, hypotension, you can see agitation, you can see diarrhea, you can see a lot of other problems, but always concentrate on the big three, the big four really in hyperthyroidism: tachycardia, atrial fibrillation, hypertension, hyperthermia. Tachycardia, atrial fibrillation, hypertension, hyperthermia. Okay. So I don't think we have to worry too much about that. Just remember, we're going to try to reduce your thyroid or functional thyroid hormones with our medical agents. And you're going to treat and protect your patients from their underlying symptoms. So, a lot of information in a really short time. I'm so grateful that you joined today. I thank you always for being here for Tuesday Topics. I hope you found something that was really meaningful to you. I'm going to end the recording now, but those of you on the line, please stay on the line so we can have a discussion. Thank you so much. I'll see you soon, maybe tomorrow, for Wonderful Wednesday's topic. Thank you so much. Stopping my recording, but not leaving the program.